So I'm presenting a post-traumatic medial femoral condylar loss. Yeah, so this patient came to us like this. 70-year-old female, obese, osteoarthritis also associated. Trauma was about 18 months ago, underwent 4 surgeries which failed, and there was a in between history of infection. At present, aseptic. So this was her story. This was a first fracture, very simple, and accidental fall, and somebody put plate. Unfortunately, got infected. So 2 more surgeries, debridement, everything was done. Somebody tried to do debridement, remove the plate, and put the screws, but eventually it was again persistent infection. So the surgeon removed the screws, debrided multiple times, and luckily 5 months. This is a medial scar, you can see. This is a 5 months aseptic. We have done all the investigation, so we confirm there is no evidence of infection, but still you have to take care. So this was a condition. uh, 5 month aseptic, skin is healed as shown in the slide.
Yeah, Dr. Bhosale, can I interrupt you at this point and
Please.
just
Yeah.
ask you a question which is very important for the audience. Number one is, if you have a suspicion of infection, or in this case, actual infection in the past,
Yeah.
and a surgeon has done a couple of surgeries, and now how do you determine that this patient has no infection? What are the ways you can determine that, okay, this patient now, or this knee is now aseptic? What are the ways
Okay.
to find it out?
Now, any patient post-traumatic with any trauma surgery, first thing and most important, as you pointed out, you must rule out infection. So we have all the history of any infection, local examination, and ESR, CRP, and the best is knee aspiration. And these are the only parameters to guide us for infection, plus intraop. Always you must take a sample intraoperatively and confirm there is no possibility of infection and take extra care.
Do you have any role of doing some bone scan or MRI scan or CT scan to find out if there is infection?
Not a very strong this thing unless there are some special cases. But usually these parameters and suspicion is the most important, and aspiration. Now knee is very easy to aspirate, and it's very difficult to treat the infection. So hip as against is difficult to aspirate, and very infection heals up very faster in hip compared to knee.
Okay, go
Okay,
ahead.
so if you see here, the medial femoral condyle is just floating with 4 surgeries, radical debridement, everything, and luckily infection was healed. So we planned. This was an intra planning. This was a trabecular metal, and you can see the lateral femoral column is intact. So we wanted to preserve that. Otherwise, this will destroy that. So try to, one very important principle is preserve intact bone, whatever possible, and reconstruct with a stable reconstruct, so that patient is allowed to bear weight and mobilize immediately. That is the most important principle of reconstruction, apart from biological. So we use a rotating hinge. We use Tata bone graft. We almost use 4 heads of pure cancellous and covered with a gel form. And intra-op stability is very important. See that everything is properly, it's stable. This was immediately post-op. You put so rotating hinge, trabecular metal augment, Tata bone graft, antibiotic biodegradable beds you get. These are very important. And IV antibiotic as against primary, we don't advise. But in such cases, anticipated infection, previous history of infection, you must give extra IV antibiotics. So this was a patient able to walk and stand immediately, and good range of movement. Stability, that's very important. Try to preserve quadriceps. So this was a rotating hinge knee, and it was a very stable construct. Now it's almost 4 years complete, and she's walking and stable. So in conclusion, MCL deficiency requires rotating hinge. You cannot use LCCK or semi-constraint. So it requires a rotating hinge whenever there's a complete deficiency of MCL. Pre-op planning is very important. Preserve host bone. Minimum constraint. Now, you must, in this case, either you need a rotating hinge or a tumor processes. But tumor process has got a definitely lesser life than rotating hinge. And if you use a constraint LCCK, it may give rise to instability. So selection is a very important part, but as minimum constraint as possible. Always reinforce reconstruction with biology bone graft. Try to achieve stable reconstruction on table to allow immediate weight bearing and range of movement. And always try to prevent infection whenever there is a trauma surgery. Short surgical time, local antibiotic, post-op IV antibiotic cover, and antibiotic absorbable beds. These are very important things.